Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Hi everyone, before we get started, I want to talk about our sponsor, Great Seminars and Books. Focusing on geriatric rehabilitation, education, and training for the clinician, it has everything from home studies such as health promotion and exercise to on-site courses focusing on cancer rehab. There's a course for anyone looking for evidence-based practice while working with older adults. So head on over to seniorrehabproject.com/great to check it out and use code SRP25 for $25 off your next purchase. Welcome everyone to the Seniors Flourish podcast. I'm Mandy Chamberlain, your occupational therapist and host, and today we are talking the exciting topic of incontinence. It actually is super exciting. And my guest today is Krista Covell-Pierson. She's an occupational therapist, and she is also the Colorado State Occupational Therapy Association president, and I'm connected with her initially, I think, wasn't it on Twitter?
I think so.
Yeah, I think so too. And then I was like, hey, you're in Colorado. And it just kind of evolved from there. And then we finally met at the State Association, which was kind of fun. But she's on today because she is going to be talking, like I said, about incontinence and giving us lots of information, strategies, and tips that we can integrate into practice. And just kind of make sure that we are addressing it and that it is something that is definitely in our plan of care if appropriate. So, Krista, I'm excited you are here.
And I am excited to be here too to talk about this crazy subject.
I know. We all, as OTs, that's kind of what we do, right?
I know. It is. But it'll give people some structure and guidelines too of how to handle it or how to talk about it. And I think it'll be helpful.
Yeah. I'm really excited about it because, like I said, we were kind of chatting before. And I mean, I'm familiar with some basic programs. I'm not a specialist by any means in it. And I just always feel like I'm missing something or I should be doing something a little bit different. So I think this will be a really great topic. So, just kind of let's start out, Krista, talking a little bit about like your background, your journey into how you found OT and kind of what you're doing now.
Yeah, sure. So, I first just wanted to say thank you for reaching out and doing this podcast and reaching out to all these different occupational therapists and all different kinds of professionals. I think it's great work and we need it. So you're doing good stuff. So thank you. And my background and journey into occupational therapy started when I was 17 and I went to visit my aunt in North Carolina, who's an occupational therapist in the school system. And I just knew then and there that I was meant to be an OT. And ironically, I have never worked in peds. I've never worked in the schools, but
isn't that funny?
Yeah, but I am still glad that I'm an OT. And I grew up in Colorado. I was born and raised here and went to Colorado State University, where I have degrees in social work and occupational therapy. So that was where it all started. That's
really funny that you were in social work too. And maybe that's a common thing, but that's what I started college to go into is social work. And then I discovered OT and then transferred into the occupational therapy track. Isn't that funny?
It is. And yeah, I did the same thing. Mm-hmm.
I think it's probably common because it kind of has that same, helping people type of thing. Yeah. Okay. So what are you currently doing then?
Right now I own a private practice called Covell Care and Rehabilitation, and we've been in business for 12 years. And we started it after my background in OT is real patchwork, like a lot of occupational therapists, and where I have background in home health and outpatient hospitals, psychiatric hospitals. I have a big chunk of background in skilled nursing facilities and started to identify that there were a lot of people that were falling through the cracks because they didn't necessarily qualify for home health or they didn't need home health, or if people needed to or they needed occupational therapy after an inpatient rehab stay, it just didn't make sense to have them come back on an outpatient basis and do things in a really contrived environment, an outpatient clinic. So we do mobile outpatient services throughout the community in people's homes and where they work and where they play and all kinds of things. And so we do OT, PT, speech, geriatric care management, massage, and senior fitness, and soon to be counseling. So, but we're mobile. So we travel between 3 different counties to provide services. So I split my time really between managing the practice and still seeing clients, because that's an important part.
And that sounds fun.
Yeah, it is fun. Every day is different, and it's nice because, we can go and see people at an assisted living facility, or we can be seeing them at their home that they've lived in for 50 years, or we can teach them how to ride the city bus, or public transportation and stuff. So it's really challenging, but you can be really function based. And there's not really any practices out there that are set up like ours. Yeah. So never in a million years did I think that we would be offering all those services. Yeah. But it just made sense as an OT. And people always say like, well, how'd you think of that? And I'm like, I went to OT school and we were told to do treatment in people's natural context.
Yeah.
That's all there is. So, it works out really well. And the incontinence piece came because a lot of folks, when we were seeing them in the home, even though we could address, community mobility and safety and energy conservation and everything under the sun, sometimes the common denominator started to be incontinence, that was the thing that was limiting them from going back to church or being with their families. And so one of my colleagues and I decided to basically do a deep dive into the incontinence world and learned more than we ever could have imagined about treatment, and became board certified in that arena so that we can address that stuff while we're doing our OT.
Yeah. Well, it is obviously a perfect, segue between incontinence and occupational therapy. But I mean, because and also how much that impacts like daily performance, like you said, and daily function, and like people had a fall. Well, what were they doing? Sometimes they're, rushing to the bathroom because they are incontinent and they're trying to get there, or whatever the thing. Like you said, there's probably that common denominator of incontinence. And so that's really kind of a neat. So what kind of board certification is it kind of, is there only one? I'm not familiar with board certifications in incontinence. So is there like one kind, or is there like different, theories, or?
Yeah, the certification that I have comes from the Biofeedback Certification International Alliance, the BCIA, and you can go to that bcia.org and check out who's a professional in your area that's board certified to treat incontinence with that. Oh, okay. And there may be other board certifications to treat pelvic muscle dysfunction. But that's what we do. And that way we can do some of the more advanced treatments too, with internal biofeedback, electrical stimulation of the pelvic floor. So, and it also just helps the clients know that we've, done our time, because there's a lot of people out there that have done biofeedback in the past, and biofeedback got a little bit of a bad rap. Yeah. And it just wasn't being used the right way. So now when you go through the board certification, you know that you're doing it the way you should be.
Well, that's really neat. So then, I didn't really realize that was a separate or a specific certification. That's really, really kind of neat. So, so let's just talk a little bit about like what is incontinence, and like the different types, and defining what incontinence is.
Sure. So incontinence, really the basic definition is any loss of urine, stool, or gas that a client does not want to have. Okay. And we can break that down into 4 different types that we typically see. And I can just define each one of those so people can start thinking about their specific clientele and maybe what category people fit in, because depending on where they fit is going to depend on how you're going to treat it. Okay. I think that we oftentimes as generalist practitioners fall back onto incontinence is incontinence, but it's not. We have to really look at why somebody's experiencing incontinence. And the easiest one to treat, and also the most common type of incontinence, is stress incontinence. And that happens when a client has a weak pelvic floor or has difficulty contracting the pelvic floor muscles. And some of the symptoms you may see in a client that's experiencing stress incontinence are things like leaking when you're sneezing, or when they go from sitting to standing up or going up the stairs. They might have just a little bit of leakage, or they can have a lot. And it helps if you can explain how the pelvic floor muscles work, because it's actually a group of muscles that, if you think of your pelvis, your muscles are laying inside the pelvis, almost like a bottom of a basket, and they're attached to the pubic bone and the tailbone. like a hammock, and then all the organs are sitting on top of that hammock. And so just making it really relatable and understandable to clients, I think is a good place for OTs to start to, just to explain that pelvic anatomy and how things are working. So when somebody is having leakage during stress incontinence, a lot of times it's because that hammock can't squeeze the way that it needs to squeeze to hold things back. And the urethra itself comes right from the bladder, goes through the pelvic floor or goes through the hammock. And then if you think it's just like a garden hose, when you have the water on, if you put a kink in it, the water will stop coming out. And when that stress incontinence kicks in and you can't squeeze that pelvic floor hard enough, you can't put a kink in the hose. So you have leakage. So that's stress incontinence. So we can do some things with the pelvic floor to get that stronger. And that usually helps with stress incontinence.
And before you kind of go on, I just kind of wanted to note, like, I think that's important to know that, or note about, stress incontinence. Like, people, if you're incontinent, you're incontinent. Is that right? Because I think sometimes be like, oh, they're sometimes incontinent, or, and my understanding of incontinence is you're incontinent or you're not.
Yeah.
Is that, I mean, stress incontinence or not, right?
Yeah.
Okay.
And if you're incontinent, you might only experience incontinence a couple times a week, or you could be having, constant leakage all day long. But yes, it's any loss that you don't want to have, you're incontinent.
Yeah. Cause I kind of actually even find that, like, in practice, like we're filling out, like in a skilled nursing initial intake and talking to the nurse, and they're like, well, they're incontinent sometimes. I'm like, no, we're incontinent.
Yes.
Or we're not incontinent. Okay.
Yep.
Just clarifying, actually just making myself feel better that I knew what I was talking about.
You are on the ball, Mandy. You got it right. Good job.
1 point for me. Okay.
Yeah. So and you can usually too, poke through somebody's history and physical and see they've probably been assigned a type of incontinence by their physician. So that gives the therapist a good place to start.
Yeah.
So the other thing that we see outside of stress incontinence is urge incontinence. And we hear that if you watch any time of daytime TV, overactive bladder commercials are everywhere. And that's when a client is experiencing a really strong urge to urinate, and they're oftentimes rushing to the bathroom, or they're going more often than what would be considered normal. So maybe they're going, every hour instead of being able to make it at least every 3 or 4 hours between voids. That's an overactive bladder. And with overactive bladder, not all clients will actually leak urine. Some don't, but they still have that really strong urge feeling. Yeah. And usually, though, the people that we see will have gotten to the point where they are leaking. So it's also helpful as an OT if you identify that there's some, risks that look like maybe urge, but they're not having leakage. It's helpful to start treating it along with what you're doing with the client and educating your client that you're helping them prevent having leakage down the road. Because it can be so disruptive and nerve wracking, just as anybody can imagine, when you're like attached to the bathroom and you just have to keep going and going and going. And it's also a really big connection with nocturia, where people are getting up at night. So if any of your clients are getting up at night more than one time a night, there's usually some sort of abnormality going on with the bladder, whether it's incontinence or all different things, but nobody should really be getting up to go to the bathroom more than once a night. So, yeah.
As a mother of 3 children, I just need to ponder that one.
Right. So think about it. Yeah. And I will explain it to my clients too, that when they are rushing to the bathroom, even though we've heard this before a million times, I'm so careful. I always take my walker. When you are rushing to the bathroom and your goal is to get on the toilet in time, not careful. No. And I've seen so many people fall when it comes to that. And the bladder essentially is having a temper tantrum, and it's having a spasm. Maybe it's irritated, causes that huge sense of urgency. And again, it just creates this perfect storm for a fall.
Yeah.
So.
Oh, no, I know. And that's a huge area of reasons for falls that I see. It's like trying to adapt.
Yeah.
Or, if you're not in the meantime of trying to address, the incontinence, but you're like, okay, how do we get you so you're not rushing to the bathroom in the meantime? We're working on it.
Yeah. And I think a piece too that, we don't talk a lot about, but is functional incontinence, which means maybe your client can get to the toilet on time, but maybe their arthritis is so bad they can't get their pants unbuttoned in time.
Yeah.
Or their bathroom isn't safe with their walker. So then they have to, sashay down the sink to get to the toilet and leave the walker, and they go too slow and then they have leakage. So there's other things outside of the pelvic floor that can have an influence on incontinence and functional incontinence. I mean, that's OT can address that all day, every day.
Yeah, definitely.
And then there's mixed incontinence, which is just a combination between stress and urge. And you'll see symptoms of both. So maybe they cough, laugh, sneeze, and have leakage. And there's rushing to the bathroom. Then they've got both things going on, and both areas have to be treated. And then there's bowel incontinence, which is pretty self-explanatory. It's any loss of stool that they don't want to be having. And it actually also includes gas. Like if somebody has gas and they don't want to be tooting in the grocery store, that usually gets patients' attention because they don't want to be doing those things. Now, insurance will not cover what we call dry incontinence, which is when they're passing gas, they don't mean to. But if you're treating some sort of bowel incontinence or urinary incontinence, the gas piece will usually get better, and clients usually have pretty good buy-in when it comes to that.
Yeah. Well, it's like, anything, that affects, social isolation. It's like a lot of people will like not leave the home because they need to be close to a bathroom, or they have like, some other, like you said, gas or things like that they just, and then that's a whole nother topic. But, it's just, it influences, so like falls, socialization, community mobility. I mean, it just like that, like you said, kind of is a core, problem that we need to be addressing a little bit more. And I think it actually is a little bit trickier for, generalist OTs. I will have to say, because you learn a little bit in school, or you take like a continuing education, and you feel like you have, some good basic background, but it's like, how do you feel comfortable addressing it and making sure that we are doing everything we can. So what types of things do you do? Like, just, we don't have to get into super detail, but like just talking about like evaluations or do you do any like cognitive assessments to help determine if they're eligible, I guess, for that kind of thing? Because I'm sure they have to be participatory. It's not just like a passive program, right?
Right. Yeah. So there's a couple things about that we can tease out of that too. And I think, for me, when I'm seeing a client and I just have the referral for incontinence, I'm going to be my evaluation is going to be really long, just about incontinence, just maybe a whole hour. But having other clients too, where I'm treating them more from the generalist practitioner's point of view, is I can at least ask about the incontinence piece in my evaluations, find out a little bit about how that interplays with their daily routine. And then I will create time in future treatments to bring that up and bring it to the table. Because the interventions to treat bowel and bladder incontinence are usually, you have to do them really, truly one at a time to see what works. You can't just give them all to somebody at one time. It works out well for a generalist practitioner, because if you're going to spend maybe 30 to 45 minutes on all your other ADL goals, then you can create, 15 to 30 minutes or so to address the incontinence, a couple times a week, not at every treatment or wherever you're working. So you can definitely give it a thread through the visits, if that makes sense.
Okay. Well, that's kind of actually good to know. I think it's actually kind of overwhelming.
Right.
So I think sometimes it just doesn't get addressed.
Yeah. And that's one thing I find, whether it's hospitals, skilled nursing, home health, it's identified and it's documented, but it's not treated. Yeah. And that's where we as OTs can rise up and say, okay, what can we do about this? And sometimes it means you're going to carry that client all the way through where you're seeing them and you're going to address the goals, but you are going to hand off that referral to an OT like me that can deal with that later down the road. Because sometimes people are recovering from hip surgery and they had pneumonia and they've had incontinence for 5 years. It's not huge on their radar right now because they're focused on getting better from surgery. Right. That's a great time to at least know what your resources are in the community, so that you may not be the one that's going to address it, but you're going to make sure that client does get it addressed.
Yeah, definitely. And I think especially since with like, there's, always increased demands for, objective assessments and things like that. And so, like I said, if you're not using, you're not getting a referral for that, let's say you're working home health or skilled nursing, that kind of thing. A lot of people are using, like a modified Barthel index, and that is a question on there. So even if people were not necessarily asking about it before, I think at least, it's on the piece of paper, they're like, oh
Exactly.
yeah. And so, like you said, it's being documented, but it's not always being addressed. But, and it obviously depends on what your setting is in cognitive level. And I mean, there's so many other things that go into it. So do you do any kind of cognitive assessment? I guess outpatients are probably a little bit different than.
I do, but I've done incontinence treatments even when I've filled in at home health, right, or even at skilled nursing facilities. People will call and say, "Hey, can you come in and see this patient because we really think, we just need you to come in and talk to her about incontinence," and I'll just go in with somebody like that. So, yes, so we do want to figure out what somebody's cognitive level is, and on the side with more of the specialized treatments with biofeedback and electrical stimulation, I will not provide those interventions for somebody that has dementia or a more advanced cognitive impairment because they're more invasive and they do have to have higher executive functioning skills in order to participate. But if we have somebody that has some cognitive limitations or none, we can usually do, all the interventions with them, even just as compared to somebody that is alert and oriented, and is doing fine in daily life. So, that being said too, though, there's things that we can do to train caregivers at home or caregivers and CNAs, activities assistants and stuff to help integrate some of the interventions that we need people to be receiving ongoing in order to improve their incontinence. So some places, skilled nursing and assisted livings, they might do exercise groups, 3 times a week. And we can teach them exercises to incorporate into their groups that are going to actually help with pelvic floor function.
Oh, okay.
Yeah.
Okay.
So, and then going back to the evaluations, I think it is overwhelming and it can be intimidating. But like we said, if we just make sure and identify it and then at least put the link in the chain that either we're going to address it in the best way that we know how, and if we end up not having good outcomes or we don't feel comfortable or we don't have time, that we pass that along. But a couple things, I can share just a few things that I do in every evaluation that I do, if that's helpful. So a few things that we always do is I always give clients a 3-day voiding diary, and what they can fill that out. And what it is it documents when they have accidents, when they go to the bathroom, whether or not they were dry, how much leakage they had, and then what they're eating and drinking and when. And if somebody will fill that out for 3 days or their caregiver does, it's really interesting to see the trends and patterns. And you can start to identify, this client is having 2 or 3 cups of coffee every morning and then is having leakage for 3 or 4 hours after that, so you can start to see these cause and effect type things. And as an OT, it's super functional. So you can look at their routines and start talking about possible changes and make one little change at a time and see how people do. So I always do the voiding diary. I always talk about, ask them about bowel and bladder function because bowel issues, whether it's constipation or bowel incontinence or irritable bowel syndrome, those things can all cause urinary incontinence and bladder issues. So we have to know what to treat first. So if the bowel is haywire, let's treat the bowels, and then we'll move into treating the bladder. So if we start with the bladder and we don't ever touch on the bowels, we're not going to see success. So we want to talk about both of those things. And that gives us a place to start. And then we always want to talk about just eating and drinking with clients. And we want to find out how much water they're having, because a lot of times people are incontinent, so they don't drink enough.
Yeah.
And then the bladder has this real concentrated urine in it, which causes it to be irritated and have urge. And then without water or good fiber intake, then they're constipated, which puts pressure on the bladder, causes all these problems. So
it's like a cycle, isn't it?
Yeah. It's really being a detective and figuring out what people are eating and drinking will also help therapists right out of the gate know what's going on.
Yeah, that's really super helpful information to kind of get a foundation and actually see what you're working with instead of just saying okay, I'm incontinent, and you're like, okay, let's go. And you're kind of actually not really getting a full picture of what exactly is kind of going on. Okay, let's just talk a little bit about what a typical treatment would be, just in general. Like
Okay.
what would be a typical session?
So after evaluation, you mean?
Yeah. Yeah.
So I'll give you a scenario and I can even give you a scenario in like each setting of things that I've done before. But we can just start. Let's just say I have a client that is in their house and they are receiving home care, and he's had issues with his prostate before. So we know there might be some issues around that. And we found out during the evaluation and doing a 3-day voiding diary that he is taking frequent trips to the bathroom. Okay. And we know we want to see somebody voiding between 6 to 8 times in a 24-hour period. So he, at this point, is voiding more like 12 to 15 times, and mostly at night. So he's up every couple of hours through his evening. So he's super tired, more high risk to fall, and he's super frustrated. So we found that for him, what we can do is put him on a timed voiding schedule. And this is helpful across different settings, but a timed voiding schedule essentially helps the client become more in control of trying to stay dry. In skilled nursing and home health too, you'll hear, well, let's put him on every 2 hours. That's just too cookie cutter. And as the OT, we have to figure out what's going to be better. So what we did with this gentleman, and we'll just call him Carl. And so we went in and had Carl start going. He was going to the bathroom every about 90 minutes to 2 hours during the day. So we actually cut him back to going every hour during his waking hours, so that he was voiding before he would have leakage.
Okay.
And what was happening is because he was having that urge, remember he's having that bladder temper tantrum and that spasm, and your bladder is a muscle. So it's like once it starts to spasm, we just sort of reinforce it to have those spasms when we're going to the bathroom all the time.
Okay.
By gauging him way back to going every hour, he's anticipating going to the bathroom before that bladder goes into a spasm. So we're retraining the bladder to not spasm as much.
Okay.
If there's just 1 hour that he just absolutely can't make it the full hour and he has to go ahead and go, but then go right back on your voiding schedule. So he's going every hour. Our long-term goal will be to get him so that he's going about every 3 to 4 hours in between, which we did eventually get him there. But sometimes you have to increase those breaks in between voids by even 15 minutes. So an hour and 15 minutes, and then an hour and a half. So it can be a long process, but there's an inherent buy-in from your client when they start, because they're having less issues of urge and less leakage. They kind of see like it's working right away. So we talked a lot about that. So we did, we put a little timer on his smartphone because he had a phone, and we put a little reminder on his walker, and that seemed to be helpful for him. And then the other thing that we did is we started going through what he was eating and drinking, and the biggest culprit, he's kind of a good old boy, and he drank coffee all the time, and he had for most of his life. And so we cut out the coffee, and he was willing to go to the store and get a coffee replacement. He used Kava. He was.
That would be a hard sell for me. I'm not going to lie.
And this is a man that, decades of drinking coffee. And I mean, I'm looking at him in his plaid shirt, his big belt buckle, I'm like, there's no way that this man's going to switch from his coffee habit. And he did, because he was motivated that he didn't want to have this leakage. So he did switch. And when I came in after the first week after he tried it, I thought, oh gosh, I'm going to hear how awful this Kava is. And he was like, it's totally fine. I think it was just kind of a paradigm shift for him. So we talked about other bladder irritants, and that's really easy to search online, just foods that irritate the bladder and drinks. And you can start pulling those things out and replacing them with things that are kinder to the bladder. And those take up some of your treatment times too, to really do good meal planning. And so eventually Carl went from voiding that many times during the day to falling into a normal voiding pattern of 6 to 8 times a day. So he did really great.
Isn't that stuff so exciting? I mean, that's I know.
Yeah.
I love that stuff. And then, like you said, that just influences so many other things, like, his, family and his daily occupations, safety, and all those other things. So it's just, I don't know. I love those stories.
We can also look at, he was cognitively intact, and he could participate in those things. And I think where a lot of, especially geriatric OTs, get frustrated is that in a skilled nursing facility, you have somebody that really may be really cognitively impaired. So they can't participate in,
Yes.
I'm going to toilet myself every hour and 15 minutes.
Right.
But what you can do is educate your CNAs and nurses, do the voiding diaries with them, have them fill it out, make it really simple so that you get their good buy-in, put a bullet or a clipboard in the bathroom, make it a fun picture that they know that means that they're working with you on those things, and get your 3 days. And if it's not a really perfect 3 days, OTs don't need to get twisted about that.
Yeah.
Just check it out. You can actually start to also identify, this client is drinking cranberry juice all the time, because cranberry juice is great to prevent a urinary tract infection. It's also really irritating to the bladder. And so we can pick those things out and start changing things, and then see if you have less people or, less episodes where the client is asking to go to the bathroom every 20 minutes, because we've all seen clients like that.
Yes.
And how to really create a better routine for that specific client. We've done that a lot in skilled nursing facilities, and it goes really well.
Yeah. And you can totally see the buy-in from the staff if they don't have to toilet someone, especially someone who's like using a Hoyer. I can see the buy-in would be a little bit better. And the idea is just to get a good routine.
Right.
So it's better for the client and better for the staff. And like the whole situation probably that much easier.
Yeah. And I think that with even the generalist of generalist practitioners, you can do a 3-day voiding diary. You can create a program around that. You can find out what irritates the bladder and what doesn't. And you can integrate that into your treatments, no matter what setting you're working in. And the other thing that we have found that we do all primarily geriatrics in my practice too. But what we've ended up doing is some of our own therapists have gone through treatment after having babies, or they're a marathon runner and they leak when they run, those types of things. The staff will end up coming to you for their issues. And that's a really great way to work with rapport with your staff. CNAs, nurses, we do a lot of community education too. And a lot of times it'll be the, person at the senior center will call me and say, I'm only 35, but this is what's going on. And can you help me? And we're like, sure. So you'll be surprised how many people are dealing with these kind of issues.
Oh yeah. Yeah, definitely. I could see that. Absolutely. So what kind of, like if you were doing a treatment plan specifically for incontinence, if you're seeing a patient specifically, what kind of goals? Like, is it mostly just times avoiding or education, or what types of goals do you write for them?
There's a few different types of goals that we can write. And as an OT, we always, of course, want to tie it back to function. So will this client be able to go out in the community feeling more confident? And we want to measure how often are they going out, or those types of challenges for clients. But we can also do it by measuring how many incontinence products people are using and cut that down. Or maybe we want to go from a brief to a pad in a certain amount of time, and then from a pad to plain old underwear, which is always a tricky transition for clients, and they have to gear up some confidence to try it. We can make those goals, and we can also then talk about the client's self-reporting benefit too. So if they're feeling less tired, or they're reporting less times where they're getting up at night, those types of things, and we can tie that back to improved occupational performance. Those are all good goals to include.
Yeah, those are good suggestions, because I think that's the other thing. Like you're talking about, like a generalist OT kind of just being intimidated by the whole idea of incontinence treatment. But it's like, okay, well, how do we write goals, and how do I make sure that you're just covering all the bases? So those are some really good and useful and helpful little tips for that. What do you think are some of the misconceptions in general about like incontinence or incontinence treatment?
I think there's a couple. And one is that incontinence is a normal part of aging. It's not. And it may be a normal piece of different aging processes or diseases. It's not like we all are going to, hit 85 and start leaking. That's just not true. So there's a lot of that to overcome. And also with clients, because there's this stigma that, well, my mom was incontinent, my grandma was, it's just sort of assumed. And it's not. So we have to do some education there. And I think the other misconception that I see even with physicians is having every client you see do Kegel exercises or pelvic floor contractions. And that drives me crazy because there is research out there that talks about how many Kegels you should do during the day and to be successful and how often. And you not only have your regular Kegel where you squeeze the pelvic floor and relax it, you also should be doing 10-second holds because you're going to have to build up the slower twitch muscle fibers too. So you really want to make sure that you know how to do a good Kegel program instead of just be like, well, let's just do Kegels today.
Right.
That's not the best thing. And doctors oftentimes will just say that to their clients. Well, why don't you just start doing some pelvic floor exercises? And we also have to remember, we can't see the pelvic floor with our naked eye. And the way that we can say, oh, let me look at your arm. You've had a stroke. I can see what's going on. You have tone. It's not coordinated. It hurts, these types of things. We have to take the knowledge that we have about muscle dysfunction, and we have to think about that with the pelvic floor. And some things that will help the generalist practitioner too it sounds kind of silly, but to examine the way or get a client to report the way that they void, meaning are they having a hard time starting the flow of urine? Are they starting and stopping a lot? Do they feel like they have to go again right afterwards? Sometimes that means that the pelvic floor has too much tone or it's too tight. And if you are doing Kegels on top of that, you're just going to make it worse.
Right.
If you have somebody that's had a stroke or they've had multiple sclerosis for a long time, there's coordination issues that are going on with the pelvic floor. And again, we give them a program. We're just going to reinforce that poor coordination. So those things around the Kegels, if it's a straight stress incontinence, you're pretty confident with that. You can jump right into a Kegel program. But otherwise, there's other pieces and layers to those Kegel programs.
Yeah, it kind of sounds like you said, like a physician might, make a suggestion about just doing Kegels or do whatever. It's none of it is as easy as it looks. It's kind of like when people, as an example, say OTs just teach them how to put on a shirt. Well, there's so many different things that we're looking at, proprioception and strength and sensation and, visual perceptually. And there's so many things you're looking at. It's the same thing with incontinence. You have to look at a client holistically, right, and see what exactly you need to address, and then how that impacts their daily performance as well. So it's funny, some of those things you have your patients, they say, oh, my doctor said this, and is it sometimes it's like, did the doctor really say that, or is that just your perception of that? You have to distinguish that a little bit sometimes. But yeah, you're exactly right. It's not a one size fits all, I guess, is kind of the bottom line, right?
Yeah, definitely not. And I think, it does help that OTs can have that frame of reference, that there's different types of incontinence, different things that are going on, because when you're more confident in those pieces, you're more confident in knowing what's going on with your clients and giving education and training. And there's a lot of people that will set up programs around this and, create whole treatment plans around these topics. And it just depends on the therapist. But as long as they're asking, that's huge. Like you mentioned, the Barthel, that's a great one to hit on. A lot of times I'll just ask somebody, do you ever have a hard time getting to the bathroom on time? And then they usually will just launch into yes, no, maybe. And then I'll just talk about, well, how is that affecting you day to day? And then they launch into that. And I'm like, and there's your goals right there. If they can't get to the mailbox or whatever, there's all your goals right there.
Yeah. Kind of self-presenting a bit.
Yeah, exactly.
Or, like we were saying before, you have a fall in the bathroom. You can say, okay, is there anything, were you trying to get to the bathroom fast, or were you, leaking on the way? There's kind of just looking at, like you said, the reasons behind some of these things. And then they kind of present themselves in goals in helping write some of those goals. Is there anything like, kind of just wrapping things up a little bit? Is there any top tips that you'd like to give to generalist OTs, or make sure that they are really keeping in mind when they are doing an evaluation, and incontinence may not be the forefront of the evaluation, but making sure that they're documenting on?
Yeah, I think you just nailed it right there. Is make sure you're documenting it, you're asking about it, and you're also collaborating with your team on it, whether it's your nurses, your dietary team, wherever your setting is, and making sure, again, that it's not just being left on the table as somebody's labeled incontinent, therefore they're just incontinent. They don't have to be. We can address that, whether it's through your treatments or passing it along. I think that's the biggest thing. And then for therapists just to get comfortable talking about things like, your urethra, your rectum, all these things that we're like, we can't talk about this. And just to start using that wording and talking to your clients that it's okay that they talk to you about it. And they will likely share more with you than they will even their own children. Or, their husband, because it's embarrassing. But if they know that you're confident and you are comfortable, then that's going to raise their confidence and comfort in sharing with you, and you can get to the bottom of what's going on.
Oh, that's exactly right. I think there's so many areas that we need to make sure that we're addressing. And like I said, the comfort level and using your therapeutic use of self and kind of figuring out, like, some people kind of are a little more comfortable joking around about it a little bit. And then you have some people that really need the concrete, trying to figure out what your patient needs and being able to communicate that with them. So this has been some really, really good information, Krista, and I really appreciate it. So I'm going to put in the show notes, just kind of wrapping up here. Going to talk, Krista provided all of us with a voiding diary that we all can print off and use. So I'll add that. And then I'm going to kind of just be referencing some of the certification organizations that she talked about, and also maybe just kind of linking up to some websites that have a list of maybe some of the bladder irritants and some of those things that we can maybe do to make suggestions for replacements and things like that. So I think just in closing, making sure that we're asking about incontinence is, especially if we're a generalist OT and not addressing it specifically, but making sure that we're seeing not only that we're making the appropriate referrals if needed to maybe a specialist, or making sure that we are integrating some of those issues of incontinence and how it affects their daily occupational performance and safety. So anyway, Krista,
so everybody knows too, with that voiding diary, I mean, you can change that. It gives you a template. You can totally use it the way that it is, but you can change that template to make it more fitting for your clientele. And it's not copyrighted or anything. So people can do that. And then if people want to talk to me more about incontinence or private practice or how to get involved in your state organization or driving rehab or whatever, if they want to get in touch with me, they can. And then we do consultations and stuff too. And if they just mention that they heard the podcast, we can do a 25% off piece on that stuff too.
Ooh, do you have an email that you'd like to contact you by, or just through your website, Krista?
Email is great. They can just do Krista, Krista, at covellcare.com, which is COV like Victor, ELLCARE.com.
Okay. And then I'll add your email to the show notes as well. And so I really, really appreciate you talking about the exciting topic of incontinence, but it's such a needed, and it's such a area that I think a lot of us don't feel confident on. So it's really great to get those practical tips. So and it's rewarding as a therapist because you actually see really black and white change. And that's sometimes as an OT in geriatrics, you don't get those types of change. So it's a nice feeling. Those little, exciting, can't even talk right now. Exciting celebrations. We always need those. Yeah. For not only the patient, but for us too. Yeah, exactly. All right. Well, thanks, Krista. And thanks everyone for listening. Until next time. All right. Thank you, Mandy. Hey guys, don't forget to check out our sponsors' great seminars and books. Not only do they have great home studies and courses, but they also have tons and tons of books. They have all sorts of things like geriatric clinical strategies and even documenting quality care. Those are things I definitely need to check out, so I think you should too. So head on over to seniorrehabproject.com/great and use our promo code SRP25 for $25 off your next purchase.
This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.